beg your pardon. Thank you very much for the invite.
Thank you so much. Right. So we have until 12:30 for this initial session. We have, as you can see, a lot of MPs with us and parliamentarians from the House of Lords as well, dying to ask you very many questions. With three panelists, I ask that everyone keeps it as brief and concise as they possibly can. If another panelist has said something that you agree with, simply indicate your agreement and then perhaps move on to another aspect of it. I'll start with a very open question. How has the pandemic been from your point of view so far? And I'll start with Ian.
Well, first of all, I've just to compliment all council staff right across the country. Everybody has stood up to the challenge. And it's incredible to think that back in sort of March, we were sort of desk bound. Now all council staff outside, you know, working from home, working from different areas. And that all took place in a matter of sort of 10 days. And it's really incredible to see that sort of resourcefulness that all staff have done. They've all stepped up to the plate. They've all sort of been working together, and district councils, county councils working together about delivering services for the residents. And it's encouraging to see that. But it's not just within councils, it's with the NHS as well. If you go to our local hospitals, sorry, I think we'll probably get a bit local today between the two of us, but you know, at the JR, it's very difficult to see the difference between social care and national health staff, because everybody is simply getting on with the job. And I think that's one of the key things, that people have put away structural and organisational boundaries, and how about delivering? Yes, there have been challenges, there's no doubt about it. Obviously, the increased costs that it's meant on local councils, there are substantial shortfalls, which either difficult decisions have got to be taken to make sure we balance the books, because councils do have to deliver a balanced budget, or alternatively, as we're calling for more money from central government to assist us. We've already had substantial amount of money, but more money is needed as well. And I think the key thing, the outcome for me, has been that actually local is good. It's really where the understanding of local areas, what it means for local care homes, local hospitals, local delivery, and I think that's something that's really important to come out. And as we move into the perhaps next phase of it, the urge is to say to government, trust local councils to deliver. We're ready and able, and we know our areas. And I'm sure the other panelists will agree with me that it's about knowing your local area. One size all doesn't fit everybody. So I think give us some space and give us responsibility. And of course, the funding.
Thank you very much. Philippa.
Yes, very much to echo what Ian has said to you. Certainly the past few months have been very challenging for us in local government, but I think really actually to expand what Ian said, we haven't just been getting on with the job, we've been doing a lot of new jobs and doing them in ways that have been well, novel for us, and obviously using media in doing that in ways that have been many of us quite challenging. But I think it is astonishing how well local government has risen to the challenges of it, and I think it is, as Ian has said, very much down to the fact that we know our localities, we know our people, we know our neighbourhoods and our communities, and we, I think, have been shown ourselves to be very well equipped to respond to those challenges and to respond to those local needs. And again, to echo what Ian has said, I think perhaps something we'll perhaps come to later, but I think one of my regrets is that the government has been perhaps insufficiently trusting of us in our knowledge of our localities and in our ability to put people on the ground knowing what they're doing.
As a quick follow-up to that, I mean, why do you think that is?
I think I'd probably have to suggest you perhaps need to ask a government minister or two as to you know, as to why it is they don't trust us. But it certainly has been quite evident throughout that we have not been trusted with the data, and we've not been trusted with the powers. And the combination of those two absences, I think, has very significantly hindered our ability to respond as effectively as we would wish to and as we could.
Very diplomatically put, thank you. Alex.
Yeah, thank you, Chair. I would just mention three aspects. I'm, I suppose, more like the canary in the mine shaft. I'm right at the bottom of the local authority hierarchy in a district council, serving a small district council in the northeast of Hampshire. And what we've seen is, of the 11 district councils in Hampshire, Rushmore has had the highest death rate from coronavirus per 100,000 population and has had the highest infection rate. I came across COVID-19 and the need for action locally quite early on. I'm a trustee of a local charity called the Vine Centre, which is responsible for delivering services to the vulnerable and the isolated throughout the borough. And we realised in February that we were going to have to, if you like, re-envision the whole services that we were providing very much on a face-to-face or group basis, and deliver those online, or deliver care and meals and so on to people who were vulnerable and isolated in the community. And we were able to do that. We reconfigured everything, and from March onwards, we were delivering these services. And over the past 21, 22 weeks, we've delivered thousands and thousands of care items to the local community. Now, this wasn't done in isolation from local government, because we required the funding from our local borough council to do that. And of course, we were able to make sure that they knew what was required, and they were able to back us up in that kind of way. The other thing that I would just mention that particularly highlighted the need for action in Rushmore to me was that on the 17th of February, I was sitting next to my colleague, Councillor Frank Rust, and he complained about shivering just as I was taking my sweater off. And that was the first sign that he had contracted COVID. 3 weeks later, we had a Zoom meeting, and he was clearly unwell, but he was saying, I've been to the GP tells me to ring 101, 101 tells me to go to the GP, and both of them say, you have to stay at home. 2 weeks later, he was in hospital. He'd had to go to accident emergency. And a week after that, he was dead. And this showed that the system simply wasn't working. If someone was ill, and he'd been ill for weeks, the system somehow didn't seem able to respond. And of course, that was a great loss to our borough. He was due to be mayor this current year, and it was a great tragedy for us, but has meant that it's kept me going in the need to keep finding out what's going on about COVID locally and trying to get the best services locally. Thank you.
Paul Strasburger.
Thank you, Leila. My question is about your directors of public health and whether they feel that they and their teams could have contributed more to the dealing with the pandemic. And if so, what needs to change to allow them to do so? Who would like to take that one on?
Peter?
Thank you. I think that our Director of Public Health, like other Directors of Public Health, are enormously well qualified and know their communities very well indeed. And I think that the fundamental frustration that they have felt throughout, certainly ours has felt throughout, I think it's true of others as well, is that they haven't been seen by those in Public Health England and in government as having those skills and that knowledge, and having something from their local knowledge that wasn't possible for those remotely in Whitehall. And I think, and it's a theme that I will keep returning to, the directors of public health and those of us who are politicians, but particularly, of course, the directors of public health day to day, have felt that they have not had the data that they need from central government, even now, the data that they need from central government, from the testing regime that enables them to use their people and their skills at a local level effectively. Our Director of Public Health, for example, in the middle of June, identified that there appeared to be a spike in the data in Leicester. And asked a number of questions about what that might or might not indicate, and was unable to get direct access to the data that lay behind the citywide figures in a way that would have enabled him to have predicted and perhaps preempted the local lockdown that was eventually applied to Leicester. And that inability to access the data directly and the lack of good reason for its not being made available to him has been a major frustration and handicap.
Leila, if I'd come in, I think again, this is going to sound a bit like Peter and I agreeing all morning, but I agree with what has been said. I think that one of the important things is that locally DPHs know their area, they can understand what the data actually means, and if they have that data, in particular granular level data at an early stage, it means they can work out exactly what can be done in a local area. And I think that's one of the key frustrations, having that ability to have access to good quality, quick data, but and also accurate data as well, to make sure that we know exactly where it is, and the ability for locally to be able to make devise own testing stations and testing results. I think that's another key thing.
Thank you. Before I come to Alex, Ian, if you could just answer this very briefly. Have they given reasons to you as to why they haven't been able to provide that granularity of data?
It's there's been no reasons as to the reason why. It's I think it's the sort of Public Health England ethos, and perhaps with the NHS, but certainly data is now coming available to us, but I think not sufficient. And it's this real-time data that's so important, and it's getting down to the micro ward level almost, so we can understand what it is. And one of the key things about it is having to work locally but nationally, because of course the virus doesn't recognize boundaries, and if people are working in different areas, then spikes are occurring that might not necessarily be a local issue. So I think it's important to work locally and nationally at the same time. But no, there's no reason being given to me anyway.
Thank you very much. Alex?
Yeah, sure. Thank you. I would say that this is related to the issue of identifying local hotspots. And I was very much concerned because I knew my ward. And as it happens, the town centre of Aldershot has the most deprived area in the whole country in terms of the percentage of people living on pension credit. And therefore, this alerted me to the fact these people were likely to be vulnerable. And therefore, we need to be able to identify hotspots. I put this to our chief executive in March, that this is what was needed. And the reason I was alerted to this was that at that time, Rushmore, in terms of the incidence of infection, had a rate of infection that was very much higher than Reading. Reading is a much bigger borough, and Rushmore is quite small in comparison. And so I was saying, why is it that Rushmore has such a high infection rate compared with Reading? And we need to identify local hotspots. And I was told, well, this is a matter for the Hampshire Local Resilience Forum. And it went to them and nothing came back. And then when I was eventually able to track down local data, which I was able to find online from Public Health England, but not until August, this indicated that indeed this town centre of Aldershot was the area where the most infections were occurring in the whole of Rushmore. And so this data must be made available to local authorities. I mean, the issue, as I understand it, is confidentiality. If you identify data on too granular level, this means that perhaps, you know, I may be able to go to a care home in my ward and say it must be there, and therefore, you know, it's an issue of confidentiality. But councils are used to dealing with confidentiality all the time. That's what they're all about. I mean, we've had extensive training on GDPR and so on. It's second nature to us to treat data confidentially. Thank you.
Dr. Philippa Whitford.
Thanks very much, Layla. I mean, really, to follow on with that, if I could start with Peter and then Ian particularly. Obviously, you've already talked about the difficulty in getting data, which allows you to spot an outbreak early, but it's also the issue of getting test results so that local DPHs and their teams are involved in test, trace, isolate. I mean, the figures reported from parts of England show only half of contacts actually being found and contacted. In Scotland, it's almost 99%. It's similar in Northern Ireland, both of which are places where it's local public health teams. So if I could start with you, Peter, because obviously all of a sudden the Pillar 2 data revealed a huge surge in Leicester, which your team hadn't been informed about. Is that data coming through now? And is your public health team actually getting results so that they're involved in the test, trace, isolate process?
The short answer to that is in part. It is better than it was, but it is still inconsistent. It's still erratic. It still comes through after a very significant time delay. And it, of course, does mean that although we do the follow-up testing, the follow-up tracing ourselves now very effectively and complement the process, it is happening far too late because sometimes it is.
How big a delay? What kind of delay are you talking about?
Well, we're talking about something that was over a week in one case, but I will undertake to follow this up with some analysis of just how long the delays are. But they certainly do mean that people who have been identified as having the disease are out in the community without their contacts being traced in a way that is certainly not effectively and in a timely fashion addressing the disease. I would just want to take this opportunity just to say that we, of course, did seek, as many other councils no doubt will have done, to develop our own data very early on in the lockdown, and to look at the two sources of information that we do have available at the local level. One, sadly, is deaths, and of course we can identify where those deaths are, the place of residence of those who die, and also hospital admissions and where they came from in the community. And we have been plotting them by low super output areas from I think towards the middle of April, actually, and had a very good idea there of those two measures, which of course are something of a proxy for from the prevalence of the disease. By the time we got to the end of June, both of those had very, very significantly diminished. And we had every reason to believe that the rate of the control of the virus in Leicester was very similar to anywhere else. What we did not have then was the testing results that were coming through. And when they did come through, Public Health England were telling us that they were perhaps just an artifact of additional testing. And were seeking to reassure us that it perhaps was not, as we suspected it might be, something more sinister that was happening out there.
I mean, obviously, looking at the published data from Leicester from that time, when you looked at the NHS testing, the number of cases had tailed off. It looked as if you were well beyond the peak. And the issue appeared to be the Pillar 2 commercial laboratory testing, which wasn't being shared with anybody initially. And when that was added on, what you realized was there was this kind of huge surge. I mean, deaths and hospital admissions are outcomes, but don't allow you to change the course of the pandemic.
Absolutely.
So, I mean, test results is the one you need quickest. It then becomes data. So at the moment, you are still waiting several days even to get test results to your public health team.
Yes, we are indeed. And as I say, there's not just the waiting, but there is also with it an absence of the address that would be ideal. But even without the address, what we could very much benefit from having, certainly in a city like Leicester, but probably elsewhere as well, is details of ethnicity and where appropriate workplace,
So
particularly given. And I put this to Dada Harding very early on when they first started talking with us about the prospect of lockdown in Leicester, never mind there being one, and said that look, we need to know more about the positive tests that you're basing this on. Can we not have ethnicity and workplace? And was told that the government had decided not to seek to require those being tested to give either of those. I understand that some of that data is collected, but it's not something that is passed to us in a way that enables us to do as we need to do, to be able to do, which is to identify which particular communities and which particular neighbourhoods in the city are seeing a prevalence of the transmission of the virus.
I mean, obviously that still relates to data. If you were getting the test result with a contact number, that's something you can ask. I mean, we've an outbreak in a food packing factory in Fife, but despite 152 cases, only 18 of them are contacts because it was identified quickly and it's being shut down. So workplaces is quite critical. Can I come to Ian, obviously quite shortly, but looking broader than just Leicester, is this what you're seeing through the local government association? Is this a pattern that's everywhere? And it's this need not just for data, which is looking at the picture, but for test results and the funding to shift from the commercial centralized test and trace to local public health teams. You're muted, Ian. You're muted.
Always the case, isn't it? It's got and someone's always doing it. Absolutely, I think that's one of the key things, because particularly this workplace environment, it's where people are going to congregate, so it's actually going back to different areas, and I think that it's really important that we do look at it. For instance, in Oxford, obviously with the student population coming back to Oxford, we're looking at local testing with the universities, working with them to understand what can where students are coming from. And I think we do need, it comes back to good granular data very quickly and very, very accurate data, so that we can, as you say, if we've got someone's phone number or contact details, public health locally, we've been doing it for many years, track and trace when there has been diseases, sexually transmitted diseases, all these sensitive things, with two-tier working, environmental health officers in district councils, they're used to doing that when there's an outbreak of food hygiene. And in Oxfordshire, we've actually got a system where we're all working together, so we're mobilising all people who are in track and trace, and that's the sort of thing we should be doing. But it is this sort of making sure that we do get good data. And I think, as I said earlier, we do have to recognise that there's got to be some national areas, because obviously the virus doesn't just affect a locality and doesn't respect boundaries. And for instance, if something occurs in central London, then the outbreak won't be in central London, but it will be spread around the area. So we do need to have that. I know that our Director of Public Health does talk to the, I think it's 14 Southeast Director of Public Health to understand the data and trying to get it. But it does come back to, yes, we can deliver. Yes, we can, if we have the resources. And I'm grateful that it sounds as if we are coming to be local by default with a national system as well, but it's key to us.
But it's respecting that expertise and putting the funding. Thank you very much.
Thank you. Can I just ask a quick supplementary of Ian? Ian, how fast is the data getting to Oxfordshire at the moment?
Again, it's like Richard, it can be varied, and I'll certainly get back to you to find out exactly what the latest situation is. It is an evolving situation. A few weeks ago, a month ago, it was very sporadic. It's getting better. We're getting more accurate, more data and cleaner data. So I'll get back to you with the exact numbers, but it is evolving all the time. And to be fair, the data is coming quicker and speedier. So I wouldn't want to say anything that was taken away from the work that's being done.
Yep, thank you very much. Debbie Abrams. Oh, Alex had a quick thing to add. Sorry, forgive me, Alex.
Yeah, that's okay. I just wanted to add quickly about the current rate of infection, because this is the worrying thing at the moment. In Rushmore, in the past week, according to the data we're getting from the Office for National Statistics, there have been 10 infections. It doesn't sound much, but it's twice as many as there were the week before. And last month, there were some weeks when there were 0 infections. But nobody's saying anything about, what should be done to clamp down on these rate of infections building up. And this is the problem, and I dare say it's the same everywhere else. It's all very well saying, well, the rate of infections there, and it's going up a bit, and it's going up a bit more, but what can we do about it? Because we have to, we have to take action now.
Thank you very much. Debbie Abrams.
Thanks, Leila, and thank you, everybody. This is very helpful indeed. Can I quickly follow on in relation to the testing data? Because Oldham, obviously, where I represent, we are facing our own particular challenges. We did have issues in the early days, but we don't have particular issues around data and data gaps. It is more timely, and the gaps on the whole are being addressed. But I wondered, Ian, in terms of your local government association experience and so on, whether you have an overview in terms of the issues around data gaps. That was my first question, if I may. And my second is in relation, again, Ian, to what you were saying in your introduction around the issues around finance. So Oldham, not uniquely, but was predicting a 20 million in-year deficit before COVID. That's now doubled, and the investment that, or the money that the government has provided back in July, the 500 million will cover barely 5% of that loss. So again, how widely is this being experienced by local authorities? If we think that this investigation, this inquiry is about preparing if there should be a second spike, what condition will our local authorities be in to be able to respond to a second spike, given the financial difficulties that are already being faced?
Well, first of all, on the data gaps, I think that it's good to hear that things are sort of getting better in Oldham. And I think that, that's one of the key things where there's a particular area, obviously, that has then sort of people have been able to get the data in more timely and quicker. Actually, it is varied, as we've heard, from Peter as well, but it is far better than it was. I mean, that's the key thing, that it is getting better and all the time, and everybody is pressing to make sure we do get that. But it is, there is still some areas where people are sort of saying, they're struggling with data to get it in a timely manner. So I think that the better quality data all the time, can't emphasize that enough. With regards finances, well, there we are. There's the tricky question. Yes, local government is facing a particular challenge. Local government always faces a challenge. I think sometimes people can say that all they hear is local government saying that we're running short of money. But this year and next year as well, I think this is the important thing, because it's not just the impact it's having on the current year 20 to 21, it's forecasting what's going to be happening in 21, 22. And we've got to remember that now is the time that we really should be starting to work on our budget for 21, 22. But if we haven't sorted out our issues for 21, so there is a funding gap. I mean, the financial challenge has meant we've been working around £11 billion for the sector as a whole. There's still a gap of £2 billion that needs to be addressed. Some councils are addressing that in year. Oxfordshire, we're going to address that because We know that if we address it now, we've got longer rather than sort of waiting until January and having to make some really radical savings, because of course councils have to balance books. This is something that everybody seems to forget, that councils, we have to balance our books, and therefore we have to make sure we have the funds. All I can say is, from Oxfordshire's point of view, the reason we're taking the decisions now is to make sure that we are in a sound financial place. Should there be a spike, should there be a flu epidemic? I mean, you know, we forget that the flu epidemic could come along as well. So we need to be as resilient as possible. Having said that, I call on government to provide additional funding where it's shown that councils have gone that extra mile and been delivering the extra services for their residents. And ultimately, this does show that we do need a sustainable solution for the financing of social care as we move into the future.
Absolutely.
The NHS, sorry.
No, yeah. Thank you very much. I'm just conscious I was Can I ask Peter, Layla, if that's all right?
Just one second. Dan wants to come back in on Ian, okay, and then I'll come back to you to go to Peter, if that's all right, Dan.
That's lovely. Thank you.
Thank you. I think this is a general question for Ian and Sir Peter as well, actually. Just on, you've talked about the financial challenges that you're facing, Ian, going into this winter, but thinking more broadly about the interface between health and social care. We know the challenges there have already been in the last winter with discharges from hospital. Do you feel that there is the support or thinking coming from the Department of Health and government to help equip you and the broader health and social care system to work effectively during what is going to be a very challenging winter with the potential of a second spike in coronavirus?
Okay, lots there. So if we go to Peter, perhaps, sorry, Ian, and then Peter to answer. So Ian on social care, Peter to do all of that, and then we'll come to Alex very briefly.
I think the understanding is better from central government than it has been in the past, because I think that previously it's all been about the National Health Service, which is absolutely vital. We've got to protect that. And if you remember, in February, March, that's what we were trying to protect. But I think there's more understanding that actually to have a successful National Health Service, which is dealing with the acute care sector and all those acute issues, then we do need to make sure we have a good, financially sound, sustainable social care sector, because that's where an awful lot of people receive the care, and it's care in the community as well. We shouldn't just be talking about care homes, it's actually providing that care in the community. And I know that through the NHS Assembly, we are talking about that to make sure that the NHS is supported by social care, and the two have got to be made to understand that they are linked, and actually to have a successful NHS, we need a successful and sustainably sound social care system.
Peter?
Yes, I mean, clearly, I entirely agree with Ian. You know, I think that the link between health and social care is evident to us. I'm not sure it was entirely evident throughout the pandemic to the government, and certainly the decisions to discharge into care homes in those early days, I think, was a dreadful mistake, and clearly, you know, don't want to sort of overstate it, but I think it put at jeopardy many elderly people, and indeed, it's perhaps worth remembering that it's not just elderly people who are in that system, and there are many other types of provision out there that also need to be both remembered and safeguarded. I will be fair. I mean, I do believe that the government has understood better the relationship and has become more aware of the challenges to social care, and I hope that those early mistakes are ones that they will learn from.
And Alex?
Yeah, just briefly, in Hampshire, for example, there are 500 care homes, and there are also hundreds of care workers going out into the community on a daily basis. This is totally unmanageable centrally from the government. And, you know, the NHS in Rushmore, for example, where we are, you have one group, one hospital, and one clinical commissioning group. That's easily coordinated in a sense. But if you've got 25, 30 care homes, each with different kinds of management, each responding to their residents and their relatives and their staff in different ways, it's very, very difficult. And this is where it's been very difficult for this to be managed. And I think this whole issue of having to bring these two systems together, the National Health Service and this very fragmented care system together, which is proving extremely difficult. And I don't see a solution to it yet. We need some kind of forward thinking that brings the two systems together in a manageable way.
Thank you very much. Liz Saville-Roberts.
Thanks very much, Leila. I've just seen a situation with my local council here, Gwynedd, where highways have been involved with track and trace. And we went into the busiest summer season that I've ever known here. And then many highway staff actually weren't available to deal with the problems. Now, looking ahead now into the winter, there are the usual responsibilities of local authorities alongside the responsibilities that you've taken on for COVID. How do you see being able to maintain those usual responsibilities, or will there be a reduction in them, and how are you going to balance it? And I'm particularly interested also in your role with schools, although I know that's different in England to what it is in Wales. Possibly Ian, first of all.
Okay, certainly. Well, during the crisis where staff were libraries is one of the easiest ones for me to say, where obviously we closed the libraries, we redeployed those staff, similar, I understand, to highway staff in your area. I think that was the key thing about it. Now we're actually reopening our libraries, so those staff aren't available, and it will be a challenge because we do need more staff because of social distancing and restrictions to deal with people. So there is going to be a challenge in there, but I think that it's something that we have got to be flexible about. And I can't say enough how proud I am of all the flexibility that council staff is, highways people working on track and trace. That's really, good to hear. So I think that's something that we've got to be aware of and make sure that we do actually use staff in a coordinated way. And that comes back to locally, we can redeploy people quicker and speedier if needed. And I think that's one of the key things for the winter we've got to be looking for.
Peter?
Yes, I echo all of that. Interesting that we have our Director of Property is currently, I think, redeployed, well, not entirely redeployed, but he's also working on ensuring that the testing regime is working well across the city. And I think that's fairly typical of what's happening in local government. People are perhaps often, in addition to their day job, having to do lots of new tasks that are very special to these circumstances. I would say it is probably the case that the challenge for us is perhaps less than it is for some other authorities, since obviously we're a fairly large unitary authority, and we have a wide range of functions, some of which are continuing pretty much as they always did, but others of which are inevitably having to adapt. And we do have lots of opportunities for being flexible in the way we use our workforce that may not be quite as readily available to with respect to Alex, to a district council.
With hindsight, would there be any way of making that flexibility more easily to operate? And are there particular areas that are concerning you going into winter? I know what's concerning us here is child protection and some of the social services aspects of child protection.
I think that the challenges that are most evident at a local level are those that are likely to reflect back on the NHS locally. If we do get a further spike of the virus, if we do get a winter flu as well, I think it's working with them. And there's a point I think that it was Ian making right at the very beginning. It's not just what we have ourselves done in local government, it is how well we have worked with our partners and how well our partners have worked with us throughout this. And certainly, I think the interdependence of local government with those other departments, other functions, is one that cannot be overstressed.
And just picking up on you mentioned child social care. One of the things is that the new way of working for us, which within 10 days we changed the way we worked, and we were working from using computers. Actually, children do use their phones. That's the way they communicate. And some of our social workers have found that it's easier to be communicating with their clients because actually they're communicating in a way that their clients are used to working in, not a way we're used to working, if you see what I mean. So I think some of these new ways of working have really stimulated and moved local government on tremendously in ways that perhaps we wouldn't have thought would have been possible.
Yeah. If I can just mention, the most urgent issue, as far as we're concerned locally, is the whole issue of what's going to happen to jobs and unemployment in the next few months. At the beginning of this year in Rushmore, there were 1,000 people unemployed. Going forward, by the end of this year, it's predicted there will be between 6,000 and 8,000 unemployed in the best of circumstances. And if the worst happens, it will be up to 10,000 by Christmas. Local government could have an essential role to play here in cooperating with the central government in order to deal with this situation locally. I mean, it's catastrophic if you've got 15, 20% unemployment locally, and this is going to be happening around the country. How is the government going to cope with this? How is it? It can't all be down to the centralised DWP to cope with it. It must be with local government working together.
Thank you very much. I'll just go back to Debbie Abrams for a question to Peter, and then we'll move on to Caroline Lucas. Debbie.
Yes, very quickly, Peter. I just wondered if the Chancellor had fulfilled his commitment to do whatever it takes with regard to support. I see you're chuckling.
I am.
Really, that's so important, both in terms of local government finances, as I say, if we should have a second wave, to make sure we're all in a position to be able to cope with that. But also, what do you think it's important as well that we ensure that people who may be on 0-hour contracts, on minimum wage and so on, who depend on a wage, that they are supported while they do self-isolate?
Yes, I mean certainly the difficulty of many in the community of actually taking time off and self-isolating when they're in irregular forms of employment is clearly a major challenge. But to come back to the first part of your question, it is certainly the case, and we were touching on it earlier on, that we, like other parts of local government, have got a big hole in our budget as a result of this, and that hole has only been very partially filled by central government support. Very grateful for what we've got, but it still falls a long way short, and it is going to give us, probably in our case, I mean, fortunately, we're not going to need to do anything immediately in year as other places are, but other authorities with having had different impacts and with different sorts of budgets are having to face that challenge, and it's a major issue for them. What I would say, and what actually caused me to laugh, was that when they were first talking about having a local lockdown in Leicester, the Secretary of State for Health gave us an absolute assurance that the businesses in the city would receive the support he implied that was commensurate with what was given to business at the beginning of the back at the end of March, beginning of April. It never materialised.
Well, the same in Oldham, I have to say.
Yes, I'm sure it is, and I don't know whether Oldham were ever given any promises, but we were, and they never materialised, and we got I think £2.6 million in the end, which is it's a few £100s per business, and obviously it's I won't say it's neither use nor ornament, but because obviously every little helps, but it is no way near what we suggested to them we should be allowed to do, which was the the change left over, as it were, from the very first round of business support. And we, like many other authorities, found that we had been generously provided for that. Some 10, 11 million pounds, I think, was left, which will have to be returned to the Treasury when it could have been used for what the Secretary of State originally promised would be available to the city.
Yeah, and Peter, can I just a quick follow-up on that? What's the consequence then of those businesses not receiving the funding? Are we at increased risk of some of them disappearing? What's happening on the ground, or have they been able to weather it?
Well, I mean, the short answer to that is it varies. I mean, obviously, some being able to hold out those few extra weeks and will no doubt bounce back very quickly. For others, no doubt, the business is failing. It is a major. A major issue for some, and for others, just a slight irritation and a slight delay. Fortunately, I mean, our city's economy is fairly broadly based and is generally quite robust. But that doesn't mean to say there won't be some fatalities amongst those businesses.
Thank you very much, Caroline Lucas.
Thank you, Leila. I wanted to ask a question about government coordination, and I know all of our witnesses have touched on different aspects of government coordination so far, but is there anything else that you would like to say about how effective it's been since the start of the pandemic? And in particular, and maybe to Peter Soulsby, first of all, because you touched on this, are there extra powers that you needed that you've struggled to get hold of? I noticed very early on in the session, you said that you weren't trusted with the powers that you needed. Could you give us some examples of what that looked like?
Yes, well, what I would have wanted us to have had was the data that I talked about earlier on, so that we knew precisely what was happening where in our communities, not just in the city as a whole, but in the communities, the neighbourhoods, the streets, and indeed the households in the city. And what I think I would have wanted us, what I know I would have wanted us to have would be the power to actually take localised action to enforce forms of lockdowns in those areas that were appropriate when we knew which communities we were talking about, which streets we were talking about, and to target what we're doing. We didn't have either the data or the power, I'm afraid.
And you be more specific about what that would have looked like in terms of being able to respond to particular outbreaks?
Well, I think it might well have depended what we knew about which communities were being affected and where that transmission was taking place. If, as is now being suggested, a significant proportion of the transmission was taking place between households and within households, then clearly, visiting one's neighbour and one's friends would have been one of the things what we would have sought to prevent happening. If, however, it was happening in a place of work, then clearly taking action to ensure either that the place of work was more COVID compliant, or indeed was closed for a period of a few weeks, or it may even have been in a place of worship, because as we know, that the extent to which there was compliance in particular areas has varied quite significantly. So it was getting the data and having the flexibility to apply different and appropriate measures at a local level, and we didn't have either.
And what was the coordination like, if I might ask you? You couldn't do those things unilaterally. What were relations like with central government when the discussions were presumably ongoing about what kind of response to be made, whether that's to workplaces?
We were invited to meetings and told very little of the government's plans, and had very little influence over them. And certainly, as the lockdown has varied and has been loosened somewhat in Leicester, we've found out most of what's been going on from news releases.
It's pretty shocking. Alex, were you indicating? Sorry. You're on mute, I think.
Yeah, I'm down. Yeah, I just wanted to say that in terms of government coordination, I haven't seen any. The problem is it's all been coming out from the centre. I've been getting daily announcements from the government, but there's no sense that the government is listening and listening to actually feedback. In order to coordinate, you need feedback, and the government doesn't seem to be responding to feedback. And this, I think Peter has just mentioned that you know, you go to a meeting and, you know, they tell you what it is. There's no listening and responding backwards. And I think this is the difficulty, is that we're perhaps it's a facet of crisis management. The centre has only time to push out stuff. They don't have time to listen and respond. That's my take on it.
We might have thought that experience to date might have changed their behaviour, but Ian, can I come to you to see if you had anything to add?
Well, one of the key areas is the local resilience forum, which is that sort of mechanism where at the local level, we can actually feed back into there, talking to our partners, understanding what's going on, and then feeding back up to central government, because my understanding is that that's where additional powers would come through. Now, again, picking up on what Peter was saying, that perhaps that's a bit clunky if we're going to be quick and effective with any sort of measures. But there is the local resilience forum to be looking at to make sure that coordination is there at that level, because I think that certainly, you know, they have the ability to operate far quicker and more effectively. And I think it's this fleet of foot, basically, where I think that we've got to be looking at how can we make sure that decisions are taken quickly, effectively. And let's be honest, if it's the wrong decision, hold our hand up and say that didn't quite work well, let's try a different method. And again, informing everybody else what hasn't worked well, because actually it's about working, sharing knowledge, because there's no point in something happening in place A that doesn't work necessarily, and then place B trying it. If you know, so I think we do need to have that coordination, and perhaps it is through the local resilience forum, rather than, because then they've got their network with the local resilience forums, rather than sort of going back to the centre all the time, because I think that is one of the issues that people have struggled with, should I say.
Just on that point about LRFs and sharing, an issue that was brought up quite early on in the calls MPs were having with Penny Mordaunt and others was a concern that LRFs weren't sharing best practice between each other, and also a separate concern being raised by those on LRFs that they weren't well resourced themselves, that they were borrowing staff from councils, and that they were concerned. Have those two issues been sorted to your knowledge?
I don't know about sharing knowledge. I mean, I think that's very disappointing to hear, I must admit, because I think that's really important. And as I say, it's not just about success, it's about what hasn't worked, because that is really, really keen, so other people don't make the same mistakes. And, you know, mistakes do happen. Resource-wise, LRFs are still basically the same situation. We're relying on you know, staff and seconding staff across and working, because I think under normal circumstances, we step up LRFs in a case of when there's floods and when there's severe weather conditions, and there's a time limit on those issues. And I think that we can all understand and cope with it. The big difference for all of government is that this is an ongoing situation, and I think we do need to look at the funding for ongoing solutions rather than the stepping up. And it's key that everybody does have the ability and resilience in there. And at the moment, perhaps we do need to sort of question, are they funded correctly? Is there a different way of funding them?
Yep. Thank you very much for that. And Peter, I don't know, or Alex, if you want to comment on LRFs in general, because they are a key part of.
No, I would just entirely agree with Ian. I mean, certainly, I don't think the structure of LRFs was envisaged with something as protracted as this in mind. Yeah. And I think there is a case now to review how they're established and how they are funded, with the view that perhaps they might be funded in rather different ways if there are ongoing and protracted situations such as this, while perhaps they are fit for purpose in normal circumstances, perhaps not fit for this purpose.
Yeah, sure. I would just say that what I would like to see is the LRFs have a higher profile, because they're a body in the background, and so people don't really know what they're up to. And so I would think they would need much more of a higher profile so that people in local communities will know that these issues are being taken care of at that kind of level.
Well, thank you very, very much, everyone. We
What about
yes,
question on flu?
oh yes, please go ahead.
I'd be very grateful to hear what our local authorities are doing about the organisation of flu vaccine, because the combination of coronavirus and flu could be really very complicated. And local surgeries don't like a lot of people coming at the same time. So how's it going to be organised, the vaccine?
Well, I think the key there is to make sure that, as you say, local surgery is not necessarily the place. Can we do more out in the community? Can we do more in any sort of supermarkets and places like that? So we're actually getting out. It's working with the CCGs. It's working with all your health partners to get the best availability to ensure that, as you correctly say, that avoiding people coming into surgeries and perhaps being spreaders. So I think we've got to look in imaginative ways. And again, that comes down to local issues. And it might very well be that some local communities, it's a different answer to other local communities. And so giving that ability to the CCGs, working with the partners in local government to see how we can deliver them in a different way, so as many people have flu vaccines as possible. And I think that's really, we've got to bang that message home out there. Get your vaccine, don't wait for it, because you're absolutely right, that is a key thing for this winter.
Yep.
And it's getting to the
theme we can pick up with Public Health England in the next session, because I think they'll be very well informed to be able to give us a more detailed view of that. And I'm also very aware that it is now 12:29 and we've only got a very quick moment left. It's been it's flown by, a huge amount here. I just want to ask Ian, then Peter, then Alex, for any quick things. Is there something we've missed that is burning that you want to say to us before we wrap up? Ian?
I'd just like to say there is the opportunity from the comprehensive spending review, from the devolution and recovery bill, for government to really work with local government to find a sustainable solution to social care. And I can't emphasize that enough. And it's about all working together cross, which is what the LGA want to do, to find that solution, which then means the National Health Service will be supported. And thank you very much for this opportunity.
No, thank you. Peter?
Yes, thank you very much indeed for this opportunity. And I just really have two sort of fundamental messages, which I've repeated several times during this. But I mean, one is to say to government to trust local government. You know, we know our local communities, we know our local people, and we can be, I think, very, very helpful to the mission of local government, to central government, if we are trusted. And the other thing I would say is that part of that trust is trust us with the data. You know, let us know what is happening in our communities in a timely, in an effective way, and in a way that gives us the complete picture of what's happening at a local level. Because when you give us that, with the trust, we can actually do something very, very useful that I'm afraid during quite a long, or well, certainly during most of the time of the pandemic, we have been very much hampered in trying to do effectively.
Thank you very much.
I would just say on the finance side of things, it's urgent that local government should get the finance settlement as soon as possible. We can't wait until a budget sometime in October. We need it much earlier than that so that we can be getting on and making sure that we are on a sound basis for the next year and the years after that. Thank you very much.
Thank you very much. Well, Councillor Ian Hudspeth, Sir Peter Soulsby, Councillor Alex Crawford, thank you so much for your time and the work that you've put into this, and the extraordinary work that councillors and council officers and everyone who has been involved on this on the ground is extraordinary. And I know I echo the thoughts of all the parliamentarians here in expressing our heartfelt thanks to all of them, and also to all of you for giving evidence today. There's certainly a lot to think about. So we are now going to move on to those who are more expert in public health matters at a very topical time in public health issues at the moment. Those on the previous panel are very welcome to stay. I see many of them have gone, but I will just make sure that everyone is now here. Yes, I think they are. So let's move on to panel number 2. So we are very, very grateful to have with us Professor Martin McKee. Have I pronounced that right? Is it McKee or McKee?
McKee. Correct.
Thank you very much. He's a professor of European Public Health at the London School of Hygiene and Tropical Medicine. Dr. McKee is also a research director of the European Observatory on Health Systems and Policies, a unique partnership of universities, national and regional governments, and international agencies. Professor McKee, you are very welcome. Thank you so much for coming.
Thank you.
Thank you. Dr. Isobel Braithwaite has joined the National Public Health Speciality Training Programme in 2018. Since then, she worked as a public health specialty registrar in local authority, local health protection, national PHE and academic roles, the latter in an academic clinical fellow at UCL. And this year, she's been involved in the public health front line of COVID-19 response with PHE's London Coronavirus Response Cell in assessing concurrent risks from extreme weather events and COVID-19 and undertaking research on automated contact tracing and the impacts of COVID-19 among people experiencing homelessness. Dr. Isobel Braithwaite, thank you so much for coming. Have I pronounced your name correctly? I'll take that as yes. And finally, but not least, Dr. Alexander Allen. Dr. Alexander Allen is medically trained ST5 registrar. In his final year of training, he became a public health consultant employed by the NHS with an honorary contract with PHE for health protection work. He worked for a year at Lewisham Local Authority, working on cancer strategy and on reconfiguration of children's mental health services. For the last 8 months, he's been at a field services in PHE, working on the COVID-19 pandemic, both from the front line and also from a high level perspective. He's also the chair of the Specialty Registrar Committee, a national committee within the Faculty of Public Health that acts as a voice for the wider registrar body on a wide range of issues, including policy and advocacy. And I know that there's been great anticipation for this panel. There's a huge amount of knowledge contained here in front of us and lots of questions to ask. So to that end, if you agree with something that another panelist has said, please just say that and don't repeat it. We want to make sure we get the maximum information out of you as possible. And as ever, we will endeavour to ask short questions and if I could ask for concise answers. But I'll start with a very broad one, a very topical one. We've heard about this reorganisation of Public Health England very recently, and I would love your take one by one on whether you think this is a good idea, and perhaps we could start with Professor McKee.
Well, thank you very much. I'm not at all clear what the problem is that it's meant to be solving. That's the first issue. And if we don't know what the problem that we're trying to solve is, then it's very difficult to know whether we're going to get the right answer at the end. I have to say that I do wonder where the idea came from, because when the Secretary of State has been asked many questions about this, it's not immediately clear that it's been thought out. We had a number of other organisations that have just been set up, and some, like the Joint Biosecurity Centre, have barely started operating, and yet they're now going to be merged. This must be one of the shortest lives of any organisation in history. And we are told, I mean, a number of the things don't add up, and you've already picked it up. We've been told that it's modelled on the Robert Koch Institute. Well, it clearly isn't. It clearly does not resemble what happens in other European countries. And there is a wealth of information which we've brought together on our COVID Response Monitor website. Then we have a list of essential public health operations set out by the World Health Organization. There seems to be no recognition of that. So my fundamental issue is I just don't understand it.
Thank you very much. Dr. Braithwaite.
So I would echo a lot of that, probably all of that. And I think the point about problem diagnosis is key. We, I think, have seen some problems, but it's certainly unclear to me how this is going to remedy any of those. Some of those are to do with silos between organizations, but there were decisions taken to create new organizations where perhaps existing ones could have been strengthened. And I think we have some real concerns because, And I speak here from an individual perspective, not a PHE perspective, but people have been working incredibly hard and we're facing a very difficult winter. It doesn't feel like a good time for a distraction like this. And I think it's going to make recruitment more challenging. And I think we risk losing a lot of very specialised and highly trained people.
Thank you very much. Dr. Allen? Sounding like a Dalek.
Your sound is... Can you try with just the screen?
I think the microphone.
It's not working.
I'm so sorry. I think we've got a sound problem. Do you want to unmute again and see if that works? If not, perhaps leave and rejoin.
Can people hear me?
Yes.
Is that any better?
Fantastic.
Great, thank you.
Welcome.
Yeah, sorry about that. I agree with very much with what my colleagues say, but the other key thing is this is any formation of an institute or merger of an institute is disruptive at the best of times, and we're not in the best of times. As mentioned, we're approaching winter and the flu season, and also we're in the middle of a pandemic. As has been seen in our European countries, the second wave can occur at any time. There's a risk that will happen here. This is not the time to be trying to reinvent the wheel. It's, again, as Martin said, it's not clear what we're trying to fix in the first place. The other key issue is that public health is not just about infectious disease. Health protection isn't just about infectious disease. There's a huge amount of other public health work that's done by PHE around health inequalities, health improvement. And as we've seen in COVID, those impact infectious disease. We know the elderly are more affected. We know the obese are more affected. We know those of Black and Asian minority ethnicities are more affected. All of these need to be, work needs to be continued and joined up with the health protection side. So the risk is all the links between those could be lost.
Yeah, thank you very much. We'll certainly come back to that line of questioning. Dr. Dan Poulter.
Thank you. Just a quick follow-up on that, actually. I think it's Dr. Braithwaite who raised, who got me thinking about this. But notwithstanding the concern that appears to be expressed from all three witnesses about this perhaps not being the right time for a reorganisation, and I hope I'm not unfairly paraphrasing, there's a broader point, actually, that about how effective these structures that were put in place by the 2012 Health and Social Care Act with Health Education England, Public Health England, the Department of Health, NHS England, and then we've had other structures subsequent to that. How much that, if you like, fragmentation of the health service has potentially impaired the delivery of the public health and broader COVID response. And I'd just be interested for the thoughts of the witnesses on that particular point.
Perhaps in reverse order, Dr. Allen? Oh, you've gone muted again. Oh, there we go.
Sorry, I'm still having a bit of audio issues. Could you repeat the beginning of the question? I missed the start.
Notwithstanding, I think the general point, and I hope I'm not unfairly paraphrasing you, about that this is perhaps not the right time for reform, but the broader point I'm just wanted to tease out is how much has the fragmentation of structures created by the Health and Social Care Act 2012 with PHE, Health Education, NHS England. You've now got NHSX. You've got various other structures as well that we could name. How much of that do we think has that helped hindered the national response to COVID, but specifically perhaps from a public health perspective?
Obviously, that's a really complex question, and I haven't worked in all those organisations or worked with all those organisations, so I can't comment directly on every single aspect of that. But I know from working in the field service team at PHE, which is a regional team that does epidemiology analysis and data collection and provides that support to both the national and local teams, that the links, a lot of the work done had to be signed off by multiple different parties, including Department of Health and Social Care, including the Cabinet Office. And while that level of scrutiny does mean that that everyone gets their view and gets to put input into this, it does slow things down a lot. And particularly when in a pandemic response, the evidence can be changing on a weekly or even daily basis. Often having that level of fragmentation or requirement for sign-off can slow things down. And indeed, we saw this. I also worked partly on the development of the app initially when it was first being developed. And again, lots of input from lots of different people, very, very expert people, very smart people. But the fact there were so many people trying to get in on it in some ways did mean things were delayed. And so I think there's definitely a level of sort of bureaucratic paralysis at some points. Again, this is, again, a personal view from my personal experience. Obviously, other people in PhD will have different views.
Yeah, thank you. Dr. Braithwaite?
So I think there's a lot of complexity behind that. And I would say in relation to the kind of question of fragmentation, clearly there were a lot of new structures created in the wake of the 2012-13 reforms. On the actual public health side, PHE brought together a lot of organisations. And I think that has taken time to kind of bed in and for links to be formed between those, but that has been happening over recent years. And I would also say that at the more local level, local health protection teams have been forming relationships with local NHS bodies, local authorities, care homes, and so on. And so I'm worried a bit that you risk further fragmentation by potentially moving those into new structures and changing who's working in which roles and so on, and a loss of institutional memory. I can't speak very much to the NHS side of it because it's something I've got less experience of, but I have certainly heard views that the strategic health authorities were a very helpful kind of coordinating force at the sort of regional level from the health side, that, you know, that can work very closely with local resilience fora and bring people together at that more regional level, which we did lose in those reforms. Now, how that would have fared in this pandemic, I suppose we can't really know. The other point I'd like to make is around transparency, sort of an accountability. I think where the HPA was an arm's length body, PHE is an executive agency. And by virtue of that, Alex's point about kind of the need for government sign off on any public health guidance that comes out, and then the lack of clarity on what the underlying kind of rationale and drivers for some of those decisions are for both members of the public and also for frontline health professionals, and the inability perhaps to explain and justify those to try and build trust can be really challenging. And I think makes the case from my perspective that a greater degree of separation, so that you know what the public health advice is before that's necessarily kind of been what you might call kind of socialized within government and approved. And clearly there is a need for that partnership working, but I think at the moment the lines are very blurred as to who's making what decisions and why.
Thank you very much. Professor McKee.
Well, I'm old enough to have to resist the temptation to keep saying I told you so. We wrote a paper in the Lancet in about, I think, 2011, during the passage of the 2012 Act, in which we actually warned about all of these things. And we were particularly concerned about the fragmentation of sexual health services, which now find themselves in between local government, PHE, the NHS. And we had that rather bizarre situation over PrEP, or the pre-exposure prophylaxis, where PHE and NHSE were almost going to court over who would pay for it. So I think we have had a legacy of problems there, but I think, as the others have said, and it's certainly what I'm hearing from my colleagues who are in senior positions, it is at the minute the need for central control, the central control that is being imposed, and not just at the Department of Health. I'm not entirely sure that many of the decisions that are being made are coming from the DHSC. I'm certainly hearing a lot of accounts of how they're coming from the Cabinet Office, and people are being instructed as to what to do, not necessarily knowing what, or why. So we do have a legacy of a problem. My sense is, and I have to say, if I go back into history, because I knew Andrew Lansley reasonably well when he was Shadow Secretary, that the bill was a great surprise. And there was a sense that public health was a bit of an afterthought. There was an argument that was being put back into local government because it had historically been there. But as people who were around at the time, Walter Holland and others who are unfortunately now no longer with us, Liam Donaldson's father, who was a very effective director of public health, people were pointing out that actually local government then and local government now are quite different, with the move of education and many other services into other areas. So there was a sense of incoherence from the very beginning. And unfortunately, that has persisted, even to the extent that the legislation on infectious disease notification, the regulations were changed in 2012, but were not amended in the bill in the regulations changed in 2010, not amended in 2012. And we now have a mismatch between the de facto and the de jure situation. And you do tend to get into, and I think it was Lord Wolfe who talked about binge lawmaking as characterising, with no disrespect to the eminent members of the legislature here, where things are not always connected, and there were contradictions in the Act, which unfortunately have led to some of the problems that we're facing.
Thank you very much for that very interesting perspective. Caroline Lucas.
Thanks so much. I love the idea of binge lawmaking. That's a phrase I shall borrow, if that's all right. I wanted to go back to something that Dr. Allen just said about health inequalities, because I wanted to ask you if you could set out in a bit more detail what the risks are of the abolition of PHE, in particular on health inequalities, because obviously eventually now there is a greater understanding in society as a whole about the differential impacts of ill health. And what do we risk by abolishing PHE essentially?
So yes, thank you for that. So yeah, PHE, this sort of, in the sort of development of the National Institute of Health Protection, there's this false dichotomy that public health is health protection and it's health improvement. And actually, to try and split the two apart is oversimplifying things. They interact with each other in every way. As I said, we've seen in COVID that obese, elderly, Black and Asian and ethnic minorities are all affected more than the baseline population. By trying to move all of Public Health England's health protection teams and services into National Institute of Health Protection, and it's still not clear to me what's happening to all the health improvement, the health inequality work, and all the other sides of PHE that have expertise, such as the health economists, the behavioural scientists, all those people with large, world-class expertise. It's not clear where they're going. I've heard that there might be a separate institute, some might be put back into the NHS, some might be put into local authority. It's still not entirely clear exactly where they're going. And if we lose that national level expertise on those health improvement, health inequality work, we'll lose the link with health protection in the first place, which is important, and we might lose the work entirely at a national level. And that would be a huge shame. There's a huge amount of work that PHE does along the lines, particularly with the government's new obesity strategy, which will be needed to be fed in at a national level as well as a local level. If we lose the national pool of expertise and put it all on local authorities or local NHS trusts, there'll be a huge loss of being able to collaborate, a loss of being able to have world-class expertise available to everybody rather than a handful of local areas. And as I said, pretending that health protection doesn't have a important link with health inequalities and health improvement is again just going to mean we'll lose that link entirely.
Thank you. Is there anything that Professor McKee or Dr. Braithwaite would want to add? So I think you're on mute. Sorry.
I totally agree with all of this, because I think what we're seeing is with the fragmentation of public health, which we already have, and this risks fragmenting it even more. Gabriel Scally in the previous hearing made the point about taking a public health perspective to all of this, and disease surveillance, infectious disease control, of course, has many technical aspects which are very important, but it's also, I think, important to have a sort of frame of mind in that you look at the various inequalities that can creep in all of this and how you might address them, because many of them are not obvious as the sort of unintended consequences of things you do.
Thank you.
I think I would just add, certainly echo everything that's been said already. I would say that the people who have expertise in health inequalities and also in areas of health improvement, things around obesity, nutrition, and far more within PHE, have made a huge contribution to the coronavirus response, a really, really huge contribution. And actually, it wouldn't have been possible without them and their expertise. So the idea that PHE's been focusing too much on obesity. Actually, the bulk of its budget and the bulk of its staff are largely focused on health protection and infectious diseases and environmental hazards already. It is already a neglected area, so it's not really that surprising if perhaps we are going backwards on health inequalities. And I think instead of saying, oh, that's been too much the focus, where actually the numbers show that it hasn't, We need to be both strengthening that capacity and also reducing silos rather than creating new ones, ideally.
Thank you.
Great, thank you very much. Actually, I'll come to Dan Poulter first for a quick follow-up on this area, but then I'm sorry to say that Professor McKee has to go. I say sorry for us, but it's because he has to go and do some very, very important things after this. So Dan, and then I'll come and ask a broad question of Dr. McKee before he has to go.
Thank you, Leila. It's just very quickly picking up on the point actually that the professor made in his comments about sexual health services in terms of fragmentation, and on Caroline's question on sort of vulnerable groups and health inequalities. And I just wondered, I mean, looking at, you know, how much do the panel, but perhaps coming to the professor first, feel that addiction services and some of the needs of those services, and indeed sexual health services, have been lost, and the patients that those services serve have been lost during the pandemic, and what could be done better?
Sure, I'll come in on that. No, I think they have, and I think the problem is that in the same way I've been working with colleagues from a range of clinical disciplines, intensive care, cardiology, respiratory medicine, and so on, because we were concerned that we were not recognizing that this is a complex multi-system disease affecting all of the different body systems. We published a paper in the British Journal of Anaesthesia, which pulled all this together, bringing people out of silos. But in the same way, a paper we published in the British Medical Journal a while back looked at the wider impact of the pandemic on mental health, on addiction, and so on. And we have a lot of evidence from other crises about the way in which all of these things are affected. And I think we need to draw much more on that. And it really highlights this thing about public health is we need the technical specialists who can do very complex sums, who can do the laboratory work and so on. But we also need people who can go across the east and can take all of these issues into account. You know, I think of it in terms of my own work, because a lot of my work has focused historically on the health impact of major social, economic, political challenges, the collapse of the Soviet Union, the 2008 economic crisis, where you're going all the way from the biology, the physiology, the pathology, up to the political science. And I think it's that ability to integrate which is terribly important, and which I think we're in danger of losing here.
And yeah, Dr. Braithwaite or Dr. Allen, you want to come in on that specifically?
I think I would just say that when we think about the concept of a second wave, we need to kind of think of that as actually multiple second waves. We need to think about the waiting lists, the impact on cancer diagnosis and treatment, the impact on mental health, the impact on sexual health services, and the ways in which all of these kind of wider impacts, whether that be mental health, whether that be drug and alcohol use, all of that is also socially stratified. So if we are serious about levelling up as a country, then we need not only to think about a second wave of infections as a risk and how we manage that, but how we best manage and minimise the impact of all of those second waves. And I think public health can play a really, really vital contribution in that work. And that, I suppose, is why we're particularly concerned. We wrote to the Telegraph after the announcement as a group of registrars to express that concern, that increasing uncertainty, risking additional people leaving the system and changing everything so that potentially it's less effective will not just impact on the infection risks, but all of those potential second waves.
Thank you. Dr. Allen?
Yes, so that's a really important point. And I'd just like to reinforce that the public health approach should look at the physical health, the mental health, the social health, and indeed economic health of the population. And therefore, we need to make sure all of those are linked. And that's kind of what we've been talking about, the siloing, the fragmentation, and the lack of joined upness in the response needs to be ready for the second wave. And as Isobel says, it's not just a single second wave.
Thank you. So Professor McKee, I know you've got to head off soon. And normally I'd ask this question at the end, but we were particularly keen to hear from you and anything that you wanted to raise in terms of preparedness for these potential waves of second waves. What needs to change? And if you had any comments, particularly on test, trace, isolate, and what needs to happen to get that to work effectively, we'd be very keen to hear your thoughts before you have to leave us.
Well, I think we really do need to get a system that can identify clusters, outbreaks as they are occurring and move in real time. You've heard in the previous session about the problems that are still persisting in all of this. We in Independent Sage, which I'm also on, we talk about find, test, trace, isolate and support. So we've got bits of a testing system, a bit fragmented. We've got bits of a tracing system with the local government taking on more of a role, but more by accident or by the local initiatives. But we don't have a joined up system. And right at the very beginning, some of you may have seen a paper we published in the Journal of the Royal Society of Medicine, where we portrayed this as a game of snakes and ladders, where you try to get as many of the ladders working and avoid the snakes. And we looked across Europe. Maybe the one thing I would say that other people might not is we do have a very valuable resource in our website in the European Observatory, the Coronavirus Monitor. We are monitoring what's going on across all of the European Union countries and beyond, some countries like Canada and elsewhere. That has detailed information on the initiatives that are being taken. And we've done a whole series of thematic reports, everything from who's responsible for, PPE and procurement and regulation through to how mortality is compared and the role of the military and so on and so forth. And it's been unfortunate that that's been very widely used by my colleagues across the rest of Europe, but there's been very little apparent interest in the UK. And I think this does come down to, it's a long-standing problem. And I would say this as a professor of European public health, I've been doing this for a very long time. But I think it's always interesting how our work is far better known elsewhere. And I will be going on, as I mentioned, to another WHO commission immediately after this, where I just think the isolationism, the exceptionalism, the unwillingness or inability to look at what's going on elsewhere has been really, really problematic all the way through. I could talk at length about that because I've got many concrete examples of where we failed to learn lessons. But we don't have time for that.
Sadly not. But Professor McKee, thank you so much for joining us today. And if you felt able to write to us with some of those examples or anything else you might have wanted to say in the session, we'd be very, very grateful. So we're very grateful for your time. Thank you for the important work you're doing, and thank you for being here today. Thank you so much. So I'll now pass to Dr. Philippa Whitford.
Thank you very much, Leila. Obviously, it's a pity that Professor McKee had to leave because him and I have corresponded on this topic before. But if I could start with Dr. Braithwaite then, and then to Alex, is very much the issue of the approach to test, trace and isolate, or find, test, trace, isolate and support. Obviously, England has gone down this commercial, centralised call centre approach, which is quite different from Scotland and Northern Ireland. Ours is very much based on local public health teams, and we are reaching almost 100% of all cases and almost 99% of all contacts. And Northern Ireland's performance is very similar. And obviously this is contrasting with approximately 50% of contacts being found by the central system in England. So it was starting with yourself, Dr. Braithwaite, what's your view on that? And do you think that can be changed or is changing? I mean, we raised in Parliament for months the issue of Pillar 2 data not being sent to public health teams. It was agreed the last week of Parliament, but the former panel suggests there's still big time delays, it's very patchy, and as if local public health teams are really not being used to the full strength of their expertise.
So there's a lot in that question, and I think just to kind of begin with, do I think things can be improved? Well, I certainly hope so, and I suppose that, whilst there are kind of many downsides to changing horses midstream, as it's been termed, greater integration, I think, between the test and trace system, the different parts of that definitely has the potential to be helpful. I think there are specific challenges that have come around by virtue of that, some of the sort of ways in which private sector and public sector labs operate differently, and lack of flexibility sometimes in terms of what's been put into contracts. So where the labs have been commissioned to provide a binary yes/no test result, if you then actually need a more detailed test result, which is called a cycle threshold, that can help you to interpret better where perhaps someone's been retested after a long period since their symptoms, and then that comes back positive. What you want to know is that still RNA from their original illness, or is this actually representing a new infection? And that cycle threshold can help you to actually interpret that and then determine whether or not this care home is going to need to take further measures and so on, which is, you know, a really big decision with lots of implications. That flexibility and that ability isn't built into those contracts. So, you know, that's one of the kind of quite specific challenges I think that people have been running into. And I hope that there are ways can be found to try and address some of those challenges. In terms of the sort of local public health team question, I think, you know, I think the situation in terms of their data access, to my understanding, has been improving. And I think the sort of the way that testing has been set up into these different pillars, it does inherently make that a little bit more challenging, because then you need to kind of integrate the data from all of those, and there are delays with that. And then also issues around data systems and data sharing agreements, I understand, have been one of the kind of blockers that's made it more difficult for data to be shared. But in terms of the... And
has that been solved, this data sharing agreements, has that been solved?
So I think Alex is probably a bit better placed to maybe comment on some of that than I am, in terms of his experience within the field epidemiology service and the data that they've been producing. I know that wherever possible, the PHE centres and regions do their utmost to provide data as needed to local authority teams, and are in quite close conversation with them. I would say that public health teams actually are often quite small and often quite lacking in analytical capacity. They've had funding cuts of in the region of 22-23% over a number of years, and they cover so many issues that haven't gone away during this. So I think, you know, if we are going to expect local authorities to be playing a really big role in that, then they clearly need the funding to be able to do that effectively. And they also, I think, benefit currently from the support and the sort of analytics that can be provided at a higher level and shared, which I hope won't be lost in this transition. I think that's really key. I don't know if that answers quite all of your question.
Yeah, I wasn't so much talking about PHE, which obviously we've already covered quite a lot, the reorganisation. It's more the actual contact tracing, you know, the use of call centres, the circle contract, etc., which I'm sure will also have the same, oh, this is what was contracted for. But, you know, we hear that public health teams locally are trying to do this, but they haven't been funded, they've not got the resources. As you say, they're quite small. So it's not, I'm not saying anything against the analytical regional input of PHE, but it's the contact tracing, someone who can recognise, oh, these villages all tend to commute to that workplace. I wonder if it's that workplace. That's what local public health teams could be bringing.
Well, I think, maybe it's helpful if I just try and briefly explain what the PHE health protection teams do, because they work at a local level, not local authority, but they'll cover a few local authorities in an area, and they'll have relationships with each of those. They do the contact tracing for all complex cases, and they do the epidemiological analysis to identify clusters. And they will be liaising very closely with care homes, with schools, with hospital infection control teams. So across that kind of whole system of maybe workplace settings as well. And people like myself and Alex and health protection practitioners that have lots of experience, because PHE normally deals with about 10,000 non-COVID outbreaks each year. Bring that experience to do those more complex sets of contact tracing where perhaps lots of people need to be traced at once. And we also there's also a link between that and the sort of more call center based part of the system. I think the numbers speak for themselves in terms of proportion of contact proportions of contacts traced, and it's around now 58, I think 58.7% in the last week for the non-complex cases which are traced through those call centres, and it's in the region of I think 90 something percent with the complex cases. And some of that's because those are in settings like care homes where actually it's quite easy to identify all of those people and take action. But some of it's probably also reflective of the years of experience that people have and the sort of higher level of training. So I think, that's probably all I'm able to kind of say on that.
Thanks very much. Obviously, that's very much around data, Alex, whereas we were hearing, if you're actually going to even identify that you have a complex outbreak, it still starts with 1 or 2 test results. And then you realize those people work in the same meat factory or whatever. So maybe you could give us more information about the speed at which test results are available, in that that's different from the analysed data, and whether you think that is moving or should move to involve more PHE and local public health teams rather than the centralised system.
Yes, so obviously this is again personal opinion. I can't speak for all of PHE by any stretch, but yeah, so there's definitely been a view that, from my opinion, that it's been a relatively technocratic approach from England in terms of a centralised, online, app-based, initially attempted approach to contact trace, including a merger of public and private sectors. And that does have advantages. It does allow very fast scaling up, but as Isobel's highlighted, there's lots of technical issues. And as you're alluding to, it does mean that local teams and local authorities are not included, or were not included initially at a very deep level. I think that is improving. I think there are lots of local authorities now starting up their initiatives to attempt to pick up where the central team are not able to contact trace. In terms of test results, I believe that's obviously been getting better over time as our test capacity has improved. I think now I couldn't speak to exactly what it is, but the turnaround times are now much shorter, and that's obviously really important. Although the guidance is, of course, that people
people getting that result.
Yeah, exactly. And so I think that's got better as well over time, as labs now feeding directly, or should be feeding directly, into health protection teams and into the contact tracing service. So I think that has got better over time, and the lab tech issues, while still an issue, have improved. At least that has been my experience of working in public health. I think that might be different in different regions. I worked covering South East and London. Obviously, there's lots of different labs, lots of different areas. In terms of the data sharing, to touch on that, again, I know from personal experience that in the field epidemiology service, we were providing daily and weekly reports on number of cases in local areas, how that's changing over time, and whether that's more or less than what we would expect based on the local area's population. From my think about week 1, basically within the first week of the contact tracing service being set up, and that data was supplied to local health protection teams and also to local authorities' public health teams. So the epidemiology has been shared quite widely and quite early. Obviously, there's lots of other data being generated, and I can't speak to how that's being shared and the difficulty of getting that. And I suspect a lot of the lab level data, particularly the difference between private and public labs, that data is probably quite different to get hold of. And anything that has patient-specific information also have a huge amount of legal requirements to make sure it's protected and safe and shared correctly, and only with those who need it. So those are always going to be difficult things to share across multiple different areas. But I know that the high-level epidemiology data and case data has been shared very early on. I hope that answers the question.
Yeah, thanks very much. Obviously, in the end of the day, if you're going to do contact tracing, it is patient-specific information that you require, and maybe that speaks to the fragmentation discussion that we had earlier on. Thank you both very much.
So much. We're going to go slightly backwards to a question on reorganisation from Simon Russell first. So please go ahead.
Yes, thank you. So Professor McKee, I think, gave us a fairly pithy view of his own reaction to the proposed reorganisation, so we can pass over that. But what I'd be interested to know is, in particular, your own experience of working with PHE and the contacts you're having with the people working there. First of all, have you, or has anybody you know, actually seen some of the work McKinsey did about the overall vision for the new organisation and its structure? And if so, do you have, or do they have, any opinion on it? Secondly, do you have any data you can give us on your view on morale within PHE and the effect that may be having on its activities? And thirdly, is there any clarity on how they're actually going to try and carry out this reorganisation in such a way that it does not impact negatively on our ability to cope with what may be a second wave? Could I put that to Dr. Allen first?
Yes, so on the first point, I personally was not aware of the McKinsey work done for this new National Institute, and from talking to colleagues, I don't think many others were. Obviously, I can't speak for everyone or the people higher up in PHE. In terms of morale, I don't really share any data specifically, but obviously it's been variable, and for the most part, and I guess the key thing to remember is a lot of these people have been working 6 to 8 months, 16-hour days, no weekend, along with weekends, no leave. So they're already exhausted. They're already really, really stretched to their limits, as it were. And to have this this announcement leaked in the press on the weekend, and then a very unclear direction of where things are going to go, how things are going to work in the future, obviously has not improved that. And particularly as we're thinking of gearing up for either a second wave or the flu season, I know from just personal contact with people, there are a lot of people who are really miffed, to put it lightly. And so I don't think I can share any specific data on that. And then your third point about the clarity of how this is going to be carried out. There have obviously been some speeches and briefings by people like Matt Hancock and Dido Harding. It's still, from my perspective, is still very unclear, particularly about the non-health protection elements of Public Health England. As I said, a lot of it's being mentioned about a second institute. I've heard mention of NHS, I've heard mention of local authority. It's not clear where each bits will go, whether there'll be multiple bits across multiple areas. It's not clear whether this institute will be funded in the same way that public health is funded. It's not clear at all where any of the funding is going. Just to remind people that, yeah, Public Health England has a budget of under £300 million per year. NHS Contact and Trace has a budget of £10 billion. It's not clear how much of that 10 billion is going to be allocated to the Public Health England side of things, or where it would have been, and whether that budget is how long that budget is protected for. So basically, to sum it up, I have little clarity on how this is going to be carried out and how this will not disrupt ongoing health protection or public health campaigns.
Thank you. Isobel?
So I would say very similar, really. I don't know anything about the McKinsey report, and I don't think I know anyone who does, at least to my knowledge. I would say that, I certainly hope that people with public health expertise were involved in that, but I still think that the fact it cost more than the entire annual operating budget for PHE begs some questions. I think my impression is certainly that morale is pretty low. And that's from a low baseline, as Alex said. People are tired. They've been working really hard because they really care about this, but public health is a lot less visible than, say, NHS work and a lot of other key workers. A lot of it is kind of calling people on phones or doing analyses or trying to improve systems and guidance. And so I think you're coming off the back of people feeling perhaps quite unseen and quite a small part of the system that gets a lot of attention in the press, shall we say, without always being able to correct misinformation there, because of that close kind of being part of government and not necessarily being able to correct things. And then in terms of kind of that clarity around disruption and the risks, my understanding is they basically said all of the kind of infectious disease and environmental hazards sort of elements of PHE are moving directly over into NIHP, which will come into force from next April, and that everyone should just, across the organisation, should just carry on doing what they were doing. But clearly, because so much of the organisation doesn't know where it's going, and because there is a lot of work that goes on across that boundary of health protection and health improvement and knowledge and intelligence and other parts, it's not that easy, I think, for things to just carry on as if this isn't happening. So yeah, that's all I would add.
Thank you.
Thank you very, very much for that. Paul Strasburger.
Thank you, Leila. I want to talk to you about where we are and where we're going. During this pandemic, we've been offered an ever-changing range of metrics for measuring the progress of the virus and our response to it. We've had the R rate, we've had deaths in hospitals only, we've had deaths in all settings, We've had new infections per day. We've had infections per 100,000 population. We've had excess deaths, which is probably my preference. In your opinion, which metric best measures the severity of the pandemic in the UK at any particular time and our performance versus other countries? Do you like to go first?
I'll go first, if that's all right, Alex. So, you know, I think maybe this is the public health person in me, a comprehensive view that looks at different metrics and tries to understand that whole picture, I think is really important. So I think from a kind of public health perspective, in terms of informing actions and next steps and priorities, we do want to see the breadth of those things. We do need that high level, that surveillance that covers all of those things. And, you know, looking at the R number is helpful because it can tell us potentially where we're going, not just where we are now. And we need to think about those kind of questions of lags and distribution across the country as well, to understand that actually we're potentially going to be seeing a patchwork of, and are already seeing a patchwork of local outbreaks. Things aren't uniform across the country. But I do agree with you. I think excess deaths is a really important thing to look at. And partly I think that because it doesn't only reflect the direct deaths from COVID, but also some of those wider harms. And so, you know, I think in terms of maybe international comparisons, it does help us to get over some of the challenges of the fact that there are different ways of assessing death. And there's no perfect way, I would say. I know I've read about the changes that we've made, and the original approach was designed to avoid undercounting. The ONS approach is quite robust, but it's slower. So it's understandable that we have different approaches. They have different pros and cons. And I think we want to look at them all, but I would agree with you. I think excess deaths is really key to look at.
Yes, I echo points Isobel made. And I think, again, to be the public health person hat on, excess deaths, while a really useful measure, obviously it's then difficult to necessarily compare internationally across all countries because different countries will have different death collection methods, but that's an aside. And the other thing that we need to consider in terms of how our country is compared to others is a lot of these, particularly when you're looking at excess deaths, a lot of the impact of excess deaths might only be felt a year from now. So I think it's to be careful about trying to interpret in the middle of a pandemic how we're doing versus other countries is a risk. And the other thing is that each of the metrics you mentioned do have their use, and why excess death is a very useful one for broad impacts of COVID. If you're looking at specifically infectious impact and things like the R number, cases in hospital, cases in ITU, all of those measures are useful. So while excess death is a really good broad one, I wouldn't try not to ignore any of the other ones because they all have uses. It's in interpretation, of course, that's important.
Yeah, I think I understand that they're all useful. I think the difficulty for the man in the street is that each one of those has sort of gone into fashion and out of fashion, and there hasn't been a sort of consistency which lets us see how the trends are going. Would you agree with that?
I think for me, this links to the fact that risk communication and public engagement are really core pillars of outbreak response. We know that from the WHO, we know it from, you know, kind of countless scientific pieces that lay out how the basics of how we should be responding to these things. And ultimately that doesn't just come down to testing or tracing or infection control. It relates to that really effective communication of risks, making sure that people really understand what's going on, what they can do to try and address it, and why that matters for them and their family and their community. And I would certainly say I've been really impressed by how Germany have approached that. I think we could learn a lot from them. I think, you know, having experts in positions of leadership and able to really speak quite independently, I think is really valuable in that. And I think from my personal perspective, that has been a bit lacking. And sometimes that communication perhaps sort of has pointed to the science as a solid concrete thing, but perhaps not in the most consistent way.
I think that's a very good point you've made there, Dr. Braithwaite, and thank you.
Right. Thank you very much. If that's, unless anyone else wants to come in on those specific points. And yes, now to Deb. Go ahead.
Thank you so much. Well, it moves quite nicely on to my question. Very nice to see you both, Alex and Isobel, and thank you. You've been absolutely fantastic. My question, as I say, relates to national and local threshold criteria for implementing lockdowns. So you've heard from Peter in terms of the whole range of different metrics, and I understand from WHO in terms of different examples across internationally about different criteria that are being used. So it will, since we're looking at the potential of a future lockdown, it's so important, as we've just been hearing about risk communication, to be clear about the conditions under which, as I say, local areas, but also a national lockdown could be implemented. Given that we failed miserably in June because we didn't have a fully operational test, track and isolate system in place in time for lifting the national lockdown, it's no surprising that many of us are in the position that we're in now. So could I hand over to you in terms of what your views are, what these should be?
Alex, do you want to go first?
Yeah. So I think that's a really important point is, as we discussed, public interpretation and understanding of data and how that's going to be then translated into national and local lockdowns. The other problem in terms of trying to communicate this is also public compliance with them as well. So and that's an issue of trust. So if the public don't trust what the government or public health teams or the data says, they're less likely to follow through with whatever lockdown occurs. And so it's a mixture of trying to make sure that what is released to the public is both clear but also consistent, and and again, because things change over time, trying to come up with any specific definition of what a single threshold for a local lockdown is going to be tricky. Obviously, there's generally things like number of cases per 100,000 population. That's often used as a metric. But also it'll be how those cases are distributed. If all those cases are in a hospital that's under relatively good control, that's different from if it's multiple different outbreaks in multiple different places, not being contact traced very effectively. So there's obviously and this is kind of where we're talking about the national versus a local. It's an understanding of what's happening locally to understand whether a local lockdown is needed or effective. In terms of national lockdown, that's obviously something that I've not been privy to in terms of the discussions around criteria for that. But that will be, I imagine, looking at if multiple different places are in local lockdown and there's still constant spread and there's people traveling between lockdowns, then it might need a national level lockdown. This is obviously just me talking about what my personal views are, not again what PHE policy would be. And then I guess the final thing is talking about the trust the public have. We know that generally over time, as time in lockdown increases, people are less likely to follow rules as precisely as they previously were. Re-entering a lockdown is going to be very tricky as well, particularly if the public do not have a trust in the public health guidance. And that's been one of the big problems in public health England is the undermining sometimes of the public health messaging just from the press, and often that's just misinformation. And so I guess another key part of that will be from the government and for whatever institute replaces Public Health England is a active attempt to disperse this misinformation, to make it clear what the guidance is, what it isn't, what the public health role is, what it isn't, what the contact tracing role is, what it isn't. Okay.
Do you think we should have published, and this applies to you as well, Isobel, should we have published those criteria? So you mentioned in terms of incidents, whether that's daily incidents, 7-day average, positivity rates, hospital admissions, should there be a handful of criteria that are developed that we then, individuals but businesses as well, can have some confidence about these are the circumstances for both local and national lockdowns?
So I think there's an advantage to that in terms of transparency, and I think that would, in some ways, that is useful. I think there's got to be some very careful, as Isobel mentioned, very careful messaging around how these are to be interpreted. And as I said, also that these are not maybe completely set in stone criteria. As I said, it will depend also on specific local factors about how these cases are being contact traced, isolated, and so on. But as you say, I agree, there's definitely a room for more independence and transparency in terms of public health messaging and guidance, with the caveat that it's got to be very carefully messaged to not be confusing or inconsistent or Because obviously, if you get, often many businesses won't have access to this specific data that the local authorities will have. So it's got to be carefully balanced with what they'll have access to and what they understand.
Yeah, I would really agree in terms of, I think, the potential benefits of that from a transparency point of view, and so that people don't. I think one of the challenges we and many others have faced during this is that we often only find out about decisions that impact on our work and that impact on, you know, many other parts of the system, either at very short notice or when we see them in the press. And, you know, that creates a lot of challenges. It undermines trust. And so the more proactive, I suppose, we can be in terms of setting out, right, this is the plan, and making sure it's really clear, really well explained, I think the better. But as Alex says, I think there always is going to be an element of judgment needed to try and kind of balance sort of the benefits and the harms, so that you're not, you know, I think we've seen certainly the benefits of acting early when it comes to outbreak control, and that's clearly got to be one of the key lessons we take from recent months, and the way that can create benefits in terms of, you know, when you're talking about exponential spread, you don't want to wait too long. But equally, you know, everyone's had an incredibly difficult year, and you don't want to be taking actions that are stricter than necessary, sort of in the wrong places, in places where they're not really having a benefit.
Thank you so much. Baroness Masham has a question, I know, on preparedness for winter flu. Baroness Masham.
Yes, I would like to ask you what preparation is being in place for flu vaccination, because the combination of corona and flu could be really very serious. And how are you going to get to the vulnerable people? And also people in care homes mustn't be forgotten. So that seems to be organization and working together as a very important thing. I'd be very grateful for your views.
Perhaps Isobel first, and then Alex.
I have to apologise because it's not something that I know that much about at an operational level. I do agree it should be an absolutely key priority. And you know that there's a team in PHE that works on immunisations, that works very, very closely with the NHS. And I know that local authorities also have roles in promoting uptake of vaccination. And certainly this year, I think the logistical sides of that will be more challenging than usual, and clearly do need funding and proper planning. In terms of the extent to which that's been going on already, I know that it's on the agenda, but I don't know more specifics, I'm afraid.
Alex?
Yes, I can't speak to the specific operational plans as I haven't worked in that area yet. But I will say, yeah, agreeing with Isobel that there is lots of work going around flu vaccination uptake, and has been going every year. There's, in terms of care homes, the local health protection teams are always send out letters, preparedness packs and things like that to care homes to try and prepare them for the ongoing flu season. Health protection teams deal with this every year, so they are very well experienced with it. The issue is, as we kind of alluded to, is if this happens at the same time as COVID, then that's going to add extra burdens, and both in terms of potential harms, but also in terms of just workload and workforce and resources available. So I'm afraid I can't answer more specifically than that.
The problem is that corona overshadows so many things, important things, and I congratulate you for all what you do. You do a lot.
Thank you very much. Thank you. And we can certainly pick up on some of those themes, I think, in future sessions. And it is now 1:31, again, gone over by 1 minute, which I consider success, and leaves me just to ask Alex and Isobel, do you have any final thoughts, any burning things that we haven't covered, anything you want to point us towards? And then just to say a final massive thank you to you both for coming and giving evidence today. It's been incredibly helpful and incredibly insightful. Alex and then Isobel.
I think the only sort of really important thing, and again, this is speaking from an informal group of registrars, is the need or the want for an independent inquiry into what went right and what went wrong. in the pandemic response. And that's not just looking into PHE, it's to look into the Department of Health and Social Care, the Cabinet Office, the various independent groups, the whole system, because trying to put the blame on any individual department or organisation is massively oversimplifying an incredibly complex system and incredibly complex response. So if we're going to learn from this, we need something independent and something that looks at the whole system.
Thank you.
But yeah, thank you very much for your time.
Yeah, I would just say thanks so much for inviting us. And really, I would welcome any opportunities to engage and work with any of you in relation to sort of ensuring that there's a meaningful consultation process, that has due time and is able to happen in a careful and a well thought out way, that really identifies the problems that are hopefully being solved, and which places health improvement and its connections with infectious diseases and health inequalities at its heart.
Thank you so much. And I'm sure we'll take you up on your expertise. Parliament, of course, returns next week, and that will give us opportunity to be able to question ministers and departments directly. And so we'll certainly be coming to you for ideas on where to hunt for that information, and also to press the case on the many issues you've raised today. So thank you, both of you. Thank you to parliamentarians for your insightful questions, and thank you as ever to the Secretariat, and finally thank you to everyone at home who is watching or watching this back on YouTube and iPlayer and wherever else it ends up in the magic of the web. So thank you. We will be having a session next week, perhaps with slightly changed times. Do look out on the March for Change website and on the Twitter account for the panelists that we're expecting there. And stay safe, everyone. Take care. Bye-bye.